I would like to introduce Anne Weldon from the Metropolitan Local Aboriginal Land Council, and Anne is going to welcome us to country.
Good afternoon, my name is Anne Weldon. Metropolitan Local Aboriginal Land Council is the cultural authority and custodian of culture, heritage, land and waterways in this particular part of Eora country. And a welcome to country is in keeping with my cultural protocol, and as an elder and with the permission of Metropolitan Local Aboriginal Land Council, I feel privileged and honoured to have the opportunity to firstly acknowledge the land on which we gather, the land of the mighty Eora Nation and Gadigal people. For the Gadigal people were one of 29 clan groups of the mighty Eora Nation. And I acknowledge each and every one here today, as you may have travelled near and far to be here. And whenever you travel across this incredible country of ours, you are entering the lands of a nation, a tribe or a clan. And we have, as Aboriginal people, existed and belong to these lands that stretches far beyond 60,000 years. And I acknowledge and pay my respect to the Gadigal people, their culture and their identity. I acknowledge their spiritual ancestors, for they shall always remain within their land, our Mother Earth. And I pay my respects to all elders past and present, and realise that our elders have made many, many sacrifices to create a better future for us all. But undeniably, history has certainly dealt my people unjust treatment, and sadly, we continue to be paralysed by these unfortunate injustices. But we are a living testament to a history of ongoing, strong commitment and determination and hardship. Certainly pride of our culture and the essence to go forward into the 21st century. And our practices of culture, language, has been handed down to hundreds and hundreds of generations. For I learnt my Wiradjuri culture and traditions by the teaching and listening to my elders. And my elders, I call them our strong, clever ones. And I ask you to celebrate, to stand with us, to walk beside us and be proud. And Metropolitan Local Aboriginal Land Council, we certainly promote a vision of working together as one community and to achieve as one community. And the boundaries for the Eora Nation spans from the Hawkesbury River to the north, the Nepean River to the west, and the Georges River to the south. So it certainly is with honour, and I feel very privileged, with the permission of Metropolitan Local Aboriginal Land Council, to welcome you all to the land of the mighty Eora Nation and Gadigal people as we gather on their traditional land. And I also thank Hepatitis New South Wales for asking me to conduct the Welcome to Country at your incredible event today. There is one special request I ask everybody every time I have the honour to conduct a welcome, is that each and every one of us remember our loved ones that have passed over before us, the incredible giants that have allowed us to stand on their shoulders, the beautiful people that are beside you right now, but more importantly, those gorgeous, precious little ones that follow in our footsteps. So may my people's spirit walk and guide all of us as we continue on our journey together, and let that journey be one where we will and continue to make our country the best in the world. So once again, welcome to the land of the mighty Eora Nation. Always was, always will be, Aboriginal land. Thank you very, very much.
Thank you so much, Anne, for that very warm welcome to country, and also for particularly reminding us about how if we work together as one community, we can achieve as one community. And I feel that that theme's important in the work that we're doing in this space around hepatitis. Our next speaker today is our keynote speaker from the Ministry of Health, New South Wales Health. I'd like to introduce Meredith Claremont, who's the Acting Executive Director of Population Health at the Centre for Population Health. Thank you, Meredith.
Hi everyone, my name is Meredith Claremont. I'm from the New South Wales Ministry of Health. and it's my pleasure to be here with you to mark World Hepatitis Day 2020. I'd like to start by acknowledging and thanking Auntie Anne Weldon for that warm welcome to country. And I'd also like to acknowledge the traditional custodians and owners of the lands on which I'm speaking to you from today. That's the Camaragal people of the Eora Nation. And to acknowledge the traditional custodians of all the lands on which you're sitting on today who are participating in today's event, and acknowledge also any Aboriginal and Torres Strait Islander people who are participating in today's meeting. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal people and their ongoing cultures and connections to the lands and the waters of New South Wales. Well, 2020, it's been a really challenging time, of course, for all of us, both personally and professionally, and supporting the health of our communities in response to COVID-19. I'd like to extend my appreciation straight up to everyone who's been working hard, those organisations, services, the clinicians, the researchers, the peers, all of the people who are participating today who've worked tirelessly to keep our communities safe as part of the public health response. Thank you. It's under these circumstances that I think it's been particularly encouraging to see the continued efforts to raise awareness and to prevent, test, treat, care for people, their well-being, those people who are at risk of and living with viral hepatitis. Your resilience and adaptability are truly commendable. The Ministry of Health continues our commitment to reduce hepatitis B and hepatitis C infections in New South Wales, and our commitment to improve health outcomes for people who are living with viral hepatitis. New South Wales has consistently high levels of antenatal screening and high coverage rates of hepatitis B vaccination. It's estimated that 1 in 3 people in New South Wales who are living with hepatitis B are not aware that they have the virus, and many of these people have come from a country where hepatitis B is more common. Peer networks and awareness-raising activities are important to encourage testing and to help support people with hepatitis B who need access to treatment wherever we can provide that. The Ministry of Health is committed to eliminating hepatitis C in New South Wales by 2028, and it's the efforts of the nurses, the doctors, the researchers, the community workers and all the peers that make this goal tangible. I want to acknowledge the work you all do every day in providing education, making sterile syringes available, giving psychosocial support, delivering opioid substitution treatments, and testing and treating people in new patient-centred ways. We know that there's been remarkable hepatitis C elimination achievements in Justice Health through systematic screening and treatment programs. The New South Wales dried blood spot pilot in prisons and in other settings has been an important tool in increasing hepatitis C testing where it would otherwise not be practical nor possible. So on World Hepatitis Day, it's worth taking some time to recognise and celebrate all of these achievements, whilst recognising that there's more work for us to do. We will of course continue to work with vulnerable populations, and we will of course continue to work in partnership with Aboriginal communities. We need to support primary care to be equipped to identify and treat more hepatitis B and C in the community. And most importantly, we know that stigma and discrimination is an ongoing barrier to people getting the treatment that they not only need, but that they deserve. We would like to recognise and thank the many people online today who are working so hard to make a difference to the lives of people living with and at risk of viral hepatitis in New South Wales. And finally, I'd like to thank Hepatitis New South Wales for inviting me to participate in today's event. Thank you.
Thanks so much. That was Meredith Claremont speaking from the Ministry of Health. Was particularly reinforcing that the goals we've set are tangible, they are within reach, which is very encouraging. And particularly if we continue to work in a patient-centred way and address the stigma and discrimination that people do experience as they're attempting to access health services, those barriers really need to be addressed in order to progress towards those tangible goals. Next, we're going to hear from Stephen Drew. Stephen is the CEO here at Hepatitis New South Wales, and I'd like to invite Stephen to introduce our strategic plan.
Hello, and thank you for joining us from wherever that might happen to be today to World Hepatitis Day 2020 New South Wales edition. World Hepatitis Day is about uniting our voices to be heard, to raise awareness about hepatitis and to be the change we want to see. And so my role today is to focus on being the change we want to see. And I'm going to do that by using this opportunity to officially launch, with much pleasure and privilege and honour, the Hepatitis New South Wales Strategic Plan 2020 to 2024. Our new plan is the result of extensive, I think is the only way to describe it, extensive consultation with our communities, including our members, our peer workers, our volunteers, as well as our partners, service providers, stakeholders and researchers. We reflected on our previous work. We looked at what we could have done better and differently. We considered what had changed over the years, which, not surprisingly, is quite a lot. And then we also imagined what the future could look like. Our new plan takes account of the fact that we're on the countdown to 2028, the New South Wales government's hepatitis elimination target date. So this is the penultimate Hepatitis New South Wales strategic plan before that magical date of 2028. So there are a number of changes in the plan, as you would imagine. We have given greater visibility to hepatitis B. So rather than just talking about viral hepatitis, we've actually separated it out so that we talk about the unique issues and considerations of hepatitis B and the unique considerations of hepatitis C. We've also more clearly targeted our work in workforce capacity building, as well as looking to address more clearly issues around stigma and discrimination that continue to blight and create barriers to access for health services. We have broadened our focus on engaging, empowering and mobilising our communities to achieve the elimination goals by 2028. And we have enhanced our efforts to grow inclusive and adaptive practices within Hepatitis New South Wales to make it and maintain it as the preeminent organisation in the hepatitis field. I could talk about and go through the number of changes that we've made in our goals, our priorities and our activities, but hey, that would take away the fun for you looking at it yourself, and I wouldn't want to do that. And also, we have a range of other really interesting people who are waiting in line after me to give you their take and share their knowledge and experience and reflections for World Hepatitis Day. So on that note, I will once again officially launch the Hepatitis New South Wales Strategic Plan 2020 to 2024 and encourage you, nay, direct you to our website, hep.org.au, where you can download your very own copy. Thank you very much for attending, and I hope you enjoy the rest of our event.
Thanks, Stephen. That was very reinvigorating. The concept that we're counting down to 2028 with the elimination goals, I think, is something to keep in mind and motivate ourselves towards further efforts. The strategic plan can be seen on the New South Wales website. Next, I'd like to introduce Professor Greg Dorr from the Kirby Institute to speak about progress towards the elimination of hepatitis C and B in New South Wales.
Good morning, everyone, and happy World Hepatitis Day. Coming from home, and we're live. No pre-record for me, and hopefully there won't be any glitches as we go through. Lovely Sydney winter day out there. Look, I just wanted to give you a little bit of an overview where I think things are up to in terms of hepatitis C elimination in Australia and New South Wales. And as we've heard, it's been a pretty uncertain last 6 months with the COVID-19 epidemic, and that really has impacted us in many, many ways. And undoubtedly, it's impacted some efforts in terms of hepatitis C elimination. It's also a reminder, I think, over the last 6 months, if we look at the global estimates for number of deaths from chronic viral hepatitis, it's 670,000 people have died over the last sort of 6 months. And it's a very sobering statistic and shows how much we need to move forward with globally. If we think about hepatitis C elimination, that'll be my focus today in Australia. We can look at it in a sense as a glass half full or a glass half empty. I'm certainly on the side of a glass half full when I think about hepatitis C elimination efforts. There has been declining numbers of people being treated every year in Australia from an incredibly high number in 2016. So 2019, it's about 11,500 people treated across Australia, and that was down from about 16,000 in 2018. So look, that's concerning. But the sort of half glass full side of things is that we've probably cured well over 70,000 people. We've brought the estimated number of people living with chronic hepatitis C down from about 190,000, our new estimate for 2015 pre-DA therapy, to what we think is around about 120,000 people now living with chronic hepatitis C. So that's an amazing achievement. We've had some really good data coming out of New South Wales in terms of looking at factors that predict hepatitis C treatment uptake through our data linkage project, where we link a number of administrative data sets with the hepatitis C notification database. And that's showing us some really encouraging signs. So around about 40% overall treatment uptake through till the end of 2018, not even factoring in 2019 treatments. I thought there'd be a lower treatment uptake among younger people, but the data linkage is showing real equity across the age groups. The other area that's absolutely essential in terms of equity is that we're demonstrating that among Indigenous and non-Indigenous populations in New South Wales, very, very similar treatment uptake. There is a little bit of a reduction in treatment uptake among people born overseas. So really demonstrating that we've got a lot more work to do to get the message through in terms of hepatitis C screening and linkage to care for people from culturally and linguistically diverse backgrounds. Also encouraging, and for me somewhat surprising, was that when we looked at it geographically, in fact, rural areas had slightly higher treatment uptake than metropolitan or outer metropolitan areas. So another encouraging sign. So some real good news, I think, on the treatment uptake side. Again, the aspect that I was a bit surprised by, but pleasantly surprised by, was that people that we might describe as having recent drug dependence, these were people who'd been admitted to hospital for complications of injecting drug use, or were on methadone or buprenorphine over recent years. In fact, had a higher treatment uptake than other subpopulations. And I don't think you could see that occurring in any other country around the world. So a lot to be proud of in terms of how we're delivering quite equitable treatment access. So what do we need to do sort of going forward? I think a few key things we need to really focus on. I think we need to move away from hepatitis C antibody as, in a sense, the diagnosis. We need to think more of hepatitis C RNA. So detection of active infection is really the diagnosis of hepatitis C. I think the dry blood spot sample pilot's really important. Point of care RNA testing technologies moving forward as well. So things that are going to make it easier to get that active infection screening done. I think the overall simplification of treatment deliveries moving forward nicely, removal of the mandatory genotype requirements, good. We've got a project, in fact, through a needle syringe program where we're looking at very simplified assessment where it's all done with a finger stick assessment. You can do HIV and Hep B serology on a finger stick, and we're doing Hep C RNA detection. So really trying to sort of simplify things going forward, I think, is really crucial. A couple of other key things that we can consider, I think, for practitioners and also clients to come forward for hepatitis C treatment, workforce development, particularly in the Aboriginal community-controlled health organisation setting, and development of a peer workforce. So a range of things we need to think about moving forward, but as I said, a lot to encourage us. So happy World Hepatitis Day, everyone, and hope you enjoy the rest of the webinar. Thank you.
Thanks, Greg. That was really wonderful to hear the glass half full side of the picture, and particularly that really encouraging information that's coming from the data linkage project that shows that you're getting more equity amongst the different subgroups of people that need to access Hep C testing. And really great news on the equity there for young people and Aboriginal people in accessing Hep C treatment as well. Yes, there is a challenge. We're seeing lower numbers of people being treated, but looking at those new technologies that are coming through, the simplification of treatment and testing is really uplifting, I think, and something to focus on into the future. So thanks very much, Greg, for that update. I'd like now to introduce Kerry Walker. Kerry is working here with us at Hepatitis New South Wales as our Aboriginal Project Officer. And I'd ask Kerry to address some of the issues for the communities with whom she works in terms of our work on viral hepatitis. Thanks, Kerry.
Hello, everybody. With the spotlight on the recent Black Lives Matter protests throughout the world, it is a stark reminder that we are not ghosts, we are not gone, nor forgotten. We remain, and forever we will. Despite all the past and current obstacles facing Aboriginal and Torres Strait Islander people, we are still here. Aboriginal and Torres Strait Islander people continue to experience health inequalities, and hepatitis B and C are no exceptions. Major factors contributing to Aboriginal lower life expectancy and poorer health outcomes originate from the effects of colonisation. The life expectancy gap may be explained by differences in the social determinants of health, which affect the health of people and can influence how a person interacts with health and other services. Racial discrimination must be recognised as an upstream determinant of health, increasing our understanding of the ways that Aboriginal people experience racism and the pathways through which those experiences have an impact on health is essential if there are to be any lasting improvements. Without fundamental change in how members of the dominant Australian culture behave towards Aboriginal people, initiatives to improve health services may have limited impact on health inequalities. Aboriginal and Torres Strait Islander peoples view health as a whole of life view that contributes to the total well-being of their community and not just the individual. The National Aboriginal and Torres Strait Islander Community Controlled Health Organisation has adopted the World Health Organisation's view to put people at the centre of healthcare, and that comprehensive primary healthcare is central to achieving real outcomes and health benefits for Aboriginal and Torres Strait Islander people, rather than a disease-focused approach. 2007 modelling estimated there were between 13 and 22,000 Aboriginal and Torres Strait Islanders living with hepatitis C. Infections in people aged under 25 years, which helped estimate the number of recent infections across all ages, was 6 times higher amongst Aboriginal and Torres Strait Islander people. Trends in hepatitis C notifications are very different. So whilst notification rates for under 25 years has been stable, the rate in non-Indigenous people has fallen. The difference in notification rates may reflect differences in injecting risk behaviours, with Aboriginal and Torres Strait Islander people twice as likely to report recent receptive syringe sharing. There are disproportionate rates of Aboriginal and Torres Strait Islander people in prison, a setting where access to harm reduction strategies is very limited. There is a need for an increased focus on culturally appropriate harm reduction strategies in both community and prison settings. The notification rate of hepatitis B in the Aboriginal and Torres Strait Islander population declined by 37% between 2013 and 2017, with the greatest declines observed in the younger age groups due to universal vaccination. However, In 2017, the rates were still more than twice as high as in the non-Indigenous population. Reflecting on the issue of hepatitis C prevalence in Australian prisons and Aboriginal incarceration, since 2004, the numbers of Aboriginal people in custody has increased by 88% compared to 28% for non-Indigenous Australians. And in 2020, 1 in 4 prisoners are Aboriginal. Half of 10 to 17-year-olds in jails are Aboriginal. The term mass incarceration is used to characterise the imprisonment of African American people in the United States, but incarceration rates of Aboriginal women and children here are 20 times that. Young males are particularly at risk due to significant reluctance to seek health care, and sometimes young males may seek health care for viral hepatitis for the first time in the criminal justice system. So why is this health gap remaining the same or widening? Well, basically, we do not have a voice and input in how things should happen. So what are Hepatitis New South Wales doing towards closing the gap in New South Wales? Well, we are working in collaboration with our like-minded organisational colleagues in a partnership to provide a holistic service and pool limited resources for expanded service provision. We have a reconciliation plan that includes targets and is reviewed and monitored by an advisory group involving Hepatitis New South Wales staff and Aboriginal community stakeholders. We provide Aboriginal resources and education services that take into consideration locational needs and issues of Aboriginal people, and we hold information stalls at our Aboriginal events. We educate on stigmatising and unjudgmental language and labels that make people feel excluded by not only the wider community but also Aboriginal communities. To be Aboriginal, a person who injects drugs and have hepatitis C can often result in threefold discrimination, stigmatisation and labelling. Hepatitis New South Wales recognises that we are only one piece of the puzzle, working alongside of Aboriginal people towards the elimination of viral hepatitis B and C. And it is not just a health sector responsibility either. This requires a whole of government cross-departmental approach. So thank you for listening to me today.
Thanks so much. That was Kerry Walker, the Aboriginal Project Officer from Hepatitis New South Wales. Very sobering information on the extremely high rates of incarceration of Aboriginal people. As you know, we have a prisons info line that takes calls directly from people in custody, and it is one of our points of access to provide information and send out some of our booklets, such as Yarning About Hep C, directly to Aboriginal people. I think the other really important take-home message Kerry's given us there is that we need to change the way the dominant culture, members of the dominant culture are interacting with Aboriginal people to really address the impacts of colonisation and look towards a whole of government approach in terms of the policy setting to increase access to healthcare and really address those social determinants of health. So thank you very much, Kerry. That was a really comprehensive coverage of some of those issues. Our next guest is Professor Carla Treloar. Carla is from the Centre for Social Research in Health, and Carla is in dialogue with Stephen Drew, the CEO of Hepatitis New South Wales. So Stephen and Carla, thank you, and welcome to World Hepatitis Day.
What would you say were the noticeable changes, if any, that have occurred in terms of attitudes and stigma and discrimination for the hepatitis sector?
I would say, depressingly, not much change. And we've known across the whole decades of life with hepatitis C, that stigma features as an incredibly important and debilitating part of some or many people's lives in living with or being fearful of having hepatitis C. So this is a key thing that we want to keep pushing and keep researching and working with community and with health policy and with health services to take action on.
Do you have a sense it's going to be much different in 2020, 21?
Yeah, well, we're measuring stigma in in a couple of different groups, you know, people living with hepatitis C, health workers, and with the general public. And so we might be able to say, yeah, there's been a good job of promoting DAAs and the curative effects of those within the groups of people living with Hep C. But the general population of health workers and the general population are so far out of our little hepatitis bubble. They're responding to issues of using the word in the literature, contagion, and fear of infection, and fear of that identity that's associated with hepatitis C, which, I mean, for drug use is tied in lots of people's minds, rightly or wrongly. And, you know, we've got a heap of work to do to shift attitudes towards people in all sorts of minority parts of society, to ensure that they're treated, that everyone receives equal treatment in health systems. We should be allowing everyone equal access, equitable access to health systems, for example, regardless of what they bring with them.
It was interesting seeing how health professionals themselves viewed how they treated people with hepatitis, as opposed to how they viewed their peers within the health sector.
This is quite powerful information to say, you know, X proportion of health workers say that they have seen their colleagues behave negatively towards someone with, and we've got a whole range of things we measure, hepatitis C and hepatitis B are some of them, and use that as an intervention to say, actually, we want people to come into the health system, and the way they're treated can be barriers to access. So we shouldn't be allowing this in our workplace, and there are ways in which we can work to better it.
Obviously, general public, as you'd expect, very different results, higher levels of stigma and discrimination.
You know, I think it's it's an interesting question. Do we worry about it? What's the general public got to do with individuals' lives? But again, our research would show that, for example, media representations of people in our sphere of interest can be really damaging to an individual living with that attribute, sorry to use that kind of language, and to perpetuating misunderstandings or stereotypes, which can then be damaging in all sorts of ways that we can't predict.
As we know, the New South Wales government has announced that it's looking at preparing mandatory disease testing legislation as well.
So, you know, this is really tough stuff. There's no evidence that this does anything in terms of protecting anybody from infection, but there's plenty of evidence that this kind of mandatory thing will drive stigma related to those 3 infections up and up and up. So it's something that we might need to unpack in our next round of surveys if that bill comes to pass for New South Wales. And again, goes to show that, you know, stigma doesn't exist in these little isolated silos. It exists in these political, legislative environments, and we need to understand those and not just the interactions between individuals that might be shaming or just based on stereotypes.
The good news is that things can improve. There are opportunities for more work. I suppose, what is it we do need to do?
What I think we need to do now is form a large, multifaceted community of practice around stigma reduction. You know, so we have the voice of community and communities, knowing that there's all sorts of experiences and those crossovers with gender, race, class, sexual identity, all of that. We need to hear from everybody, from advocates, from health workers, from health policy makers, and researchers of varieties of types, all in together to say there's already things going on. You know, Hepatitis New South Wales has run the Seen and Heard speaker program for a long time. We've done research on that. New South Wales Health has made some investments in stigma reduction training for around people who inject drugs. That's fantastic. Other places are doing things big and large scale. Let's kind of map it all out, see where the gaps are, see which looks like things that could be effectively scaled up for larger impact. And we are good at working together to produce new, exciting and effectual stuff. So that's what I'd like to see, is a way to galvanise all of those expertises and help us sort out what's scalable for big impact.
Fantastic. Carla, thank you so much. Look forward to the next report that you have.
Yeah.
And here's to more working together in partnership with us and with all of the sector. Thanks, mate. Take care.
It was really upsetting to find out I had Hep C so young, because I knew that the longer you have Hep C, the more damage it does. And I was thinking, crikey, I'm only 20. When I'm 70, I'm going to have liver cirrhosis. Like, the statistics to liver cirrhosis after 50 years of Hep C is pretty high. So yeah, I was really, really upset. I've received a fair bit of stigma and discrimination having Hep C. Mainly through doctors, because they're the ones that find out most of the time. But I've had quite a few doctors say quite a few inappropriate things. Doctors that would say, well, you should never have used a dirty needle. And I feel like that is putting the blame on me, because I really tried to use everything as safely as I could. And I feel like they assume because you're an IV drug user, you must be doing things unsafely. But it's just very easy to catch. Once I was telling a doctor I was doing a project with HEP New South Wales, and they're like, oh, so you used to be a bad girl, did you? And I thought, oh, goodness. And he started telling me all about his patients with Hep C, and saying that he didn't believe any of them that said they hadn't got it from injecting drug use. And it's not nice. And also not just what doctors think, what friends think as well. And just to feel infected. I mean, it's not nice to feel infected and to be worried people are going to catch things from you. I'd be nervous to start new relationships, because I'd be thinking, oh no, I'm going to have to tell them I have Hep C. And I'd be thinking, well, when am I meant to tell them? And it just was a real worry. So in 2016, I finally heard about the new treatment coming out. Epiclusa was the first treatment to come out. There's 4 different treatments. I just went to my GP and I said that they knew I had Hep C, and I said I wanted to do the new treatment. And they're like, well, we need to test that you still have Hep C before we can give you the new treatment. And they sent me to pathology, and I did a blood test. And then 2 weeks later, I went and got my pathology and a blood test. And they gave me a script, and that was that easy. I went to the chemist, got my script, took 1 tablet a day for 12 weeks. And I didn't feel any side effects, actually pretty much the opposite. I never really noticed Hep C dragging me down, but when I was about 3/4 through the treatment, I just got all this energy. It was just great. I recommend it to anybody. Around 3 months after I finished my treatment, I went back to the doctor just to make sure that I had cleared my Hep C, and I had cleared my Hep C, and that was a great moment. I kind of knew I'd cleared it, but it's still really, really nice to know for sure that I definitely had. And yeah, it was just, I really remember it was just so great. I was ringing my mum, and they were all very excited. Once I was cured, it was such a huge relief to me. It was I didn't have to mention it in conversation. I didn't have to worry about infecting people. I didn't have to worry about being infected or telling people. It just made me feel about myself differently. And I know you might think it's funny because I'm talking about it now, but it's different to say that you were than you are.
Thanks very much. You've just heard from the pair speaking together, the conversation between Professor Carla Treloar and then Stephen Drew, our CEO. Carla was particularly talking about how healthcare workers can be part of the solution, in that when they observe stigma being played out in terms of the behaviours and comments and so on of healthcare workers, they could address that, and addressing that behaviour can be the key to increasing people's access to health services. It's important that that bias that exists in the actual workforce is addressed in order to ensure that patients get the treatment that they deserve. And then following on from Carla and Stephen's conversation, you had one of our lived experience speakers, Grace, speaking about her experiences seeking treatment as a person living with Hep C, and particularly noting some of those surprising incidents that may well have stopped her on her pathway through to treatment. And those lived experiences are very important to understand in terms of our work and reorientating health services and being particularly sensitive to the needs of the people coming through seeking treatment. Our next guest is Mary Ellen Harrod from NUA. Mary Ellen is the Chief Executive Officer of the New South Wales Users and AIDS Association, NUA, and I'd welcome Mary to our World Hepatitis Day event. Thank you, Mary.
Hello. My name's Mary Harrod and I'm the CEO of the New South Wales Users and AIDS Association. I'd like to start by acknowledging the traditional owners of the land I'm on, the Gadigal people of the Eora Nation, and pay my respects to elders past, present, and emerging. Sovereignty of this land was never ceded. I'd also like to thank Hepatitis New South Wales for hosting this event and inviting me to present, and acknowledge the New South Wales Ministry of Health for their ongoing support of our organisation. NUA is a peer organisation. Our staff team and board of governance are made up of people with lived experience of drug use. NUA was established in 1989 during the HIV crisis with the intention of preventing the spread of HIV in people who inject drugs through peer education on safer injecting and the provision of sterile equipment. The HIV pandemic was a time of terrible loss for all of us, but it also brought opportunities to develop innovative responses to a health crisis that are still relevant today. 31 years later, NUA's brief includes hepatitis C, working closely with drug and alcohol services, prisons, and music festivals, all with a peer lens. Our work and our reach are much bigger, but our core principles remain the same. Programs and services aimed at empowering people who use drugs to access healthcare and live with dignity must be led and developed by peers, people who use drugs. Hepatitis C in Australia is overwhelmingly a disease transmitted through injecting drug use. Together, we've made incredible progress in eliminating Hep C, but we still have more work to do. Our main challenge remains the shame, judgment, and violations of basic human rights that we experience as the result of the criminalization of drug use. We are still wary of having our Hep C treated because of shame and stigma. Judgment and stigma often results in poor access to basic humane health care. It's preventing us from seeking treatment and medical professionals from offering treatment for this eminently treatable disease. The issue is bigger than just Hep C treatment access, and it can't be solely fixed by peer support or by running health promotion campaigns. It's a system-wide issue of how people who inject drugs are treated in society and in healthcare settings. There's hope for improvement. The recent special inquiry into the drug ice called for the decriminalization of personal drug use. The community is mobilizing around initiatives like pill testing. Australia has made a substantial commitment to eliminating Hep C and have led the world in making treatment accessible. Peer-based harm reduction is increasingly a core part of the health response in areas as diverse as HIV prevention and music festival safety, and is key in the elimination of Hep C. But the COVID pandemic is making it crystal clear now that most Australians care deeply about the health of the most vulnerable members of our society, and that we're willing to make significant sacrifices to protect them. We're decent and caring. COVID is also giving us a stark reminder of the very real role that social equity plays in community health, and that people with insecure incomes and housing, people who experience multiple disadvantages, have less access to healthcare to the detriment of us all. Building a genuine movement for reform will take all of us pushing for fundamental system change, including ceasing the over-policing of already marginalized people, and most especially Aboriginal people. It includes ensuring funding is available so that people who use drugs can access safe and appropriate harm reduction and health services. And yes, it includes decriminalization and eventual regulation of illicit drugs. We must learn to ignore the persistent negativity that sometimes is delivered through media outlets like the Daily Telegraph. We must continue to push for evidence-based healthcare in this most contentious of all areas, how we as a community treat people who use drugs. and our peer community must be at the forefront of this work. We need to lose the judgment and trust the significant majority of Australians, many of whom have used themselves, are rational and humane and support compassion, healthcare, and human rights for all, including people who use drugs. Today, hundreds of thousands of Australians needlessly live with Hep C. We can and we will eliminate Hep C if we work together to create change, and our whole community will be stronger and more resilient when we do. Thank you.
Thanks so much. You were just hearing from Mary Harrod, the CEO of NUA. And it was a really important message, I think, there about the successes of peer-based harm reduction as a model for getting more messages out into the community in relation to Hep C. I particularly liked your slogan, lose the judgment. I think that we've seen that kind of change, that shift in people's attitudes borne out through the COVID epidemic as much as around the issues that people have been facing as a result of that. And your call for us to work together as a whole community so that we can address issues together, I think is a theme that we could pick up as a way of working through more strongly into the future on hepatitis C. Just to give everyone a bit of background, we've got 86 people today here at our event, so it's great to have that many people joining us for World Hepatitis Day. And please stay on the event if you can, because we have 3 or 4 more speakers to talk about hepatitis C, hepatitis B, and also treatment in the custodial setting. So there's still other speakers coming up that you might find of interest. Next, I'd like to introduce Gai Stackpool. Gai is the Deputy Manager of the Multicultural HIV and AIDS Service. And Gai is going to be speaking with us about the issues for working with multicultural communities in New South Wales in the areas of hepatitis B in particular. Following on from Gai, you'll see a video of one of our lived experience speakers, Wei, and I think you'll find that there's reflection in his story on some of the issues that Gai raises very clearly in her address to the event today. So thank you, Gai, for joining us.
Good morning, everyone. It's good to be with you this morning. I'd like to acknowledge the traditional owners of the land and pay my respects to elders past, present and emerging. I'd also like to thank the team at Hepatitis New South Wales for organising this morning's event and for giving me the opportunity to talk about the challenges we face in addressing chronic hepatitis B. I'm sure you're all aware that the burden of disease disproportionately affects our vulnerable populations, especially our migrant communities and people of Aboriginal and Torres Strait Islander background. Nearly 80,000 people living in New South Wales are estimated to be living with chronic Hep B. Unfortunately, many are unaware of their diagnosis. Without appropriate management, up to 1 in 4 people living with chronic Hep B will develop serious liver disease or liver cancer. However, the good news is that we have a very safe and effective vaccine, and with appropriate monitoring and treatment, the risk of liver disease is seriously reduced. The goals of the New South Wales Hepatitis B strategy are to reduce infections and improve health outcomes for people living with chronic hepatitis B. While we've made good gains, there's still more work to be done. The challenge remains for us to continue to reach the communities most affected, not just to address gaps in knowledge, but also to enhance access to and regular engagement with health services. The communities we need to reach are diverse and experience a number of issues that influence their readiness to take up health messages. Language and literacy are obvious barriers. Resettlement issues, such as housing and employment, often take priority over health for those who are newly arrived. The experience of a migrant who plans their migration and has been in Australia for some years will be very different to that of a refugee who may have experienced trauma and civil unrest. The type of person a visa hold will determine their access to Medicare and therefore healthcare. Our efforts can be strengthened by understanding the cultural and social experiences of those living with hepatitis B. This requires meaningful engagement with the communities and those affected. Cultural and linguistic diversity is a term we commonly use to describe a large proportion of our population. However, it implies uniformity and doesn't acknowledge the diversity between and within communities, nor the dynamic nature of our migrant and refugee populations. When developing programs and services, we need to ensure that they are appropriately targeted, responsive, as well as culturally appropriate. Hepatitis B is also a complex disease, which makes it difficult to explain and understand, and a diagnosis can bring with it significant stigma and discrimination. Undoubtedly, the greatest challenge we're facing today is COVID-19. The pandemic has caused significant disruption and has had a huge impact globally, nationally, locally, and at a personal level. Resources and funding are being redirected to respond to the pandemic, and capacity for business as usual for all of us is limited. Communicating messages around health issues other than COVID is a challenge. We're being overwhelmed with information about COVID, and what we're receiving is complex and changes rapidly on a daily basis. It's hard to compete for airspace when the media reports are dominated by the pandemic. However, the pandemic has brought our attention to the gaps and complexities of providing health information. It's provided the opportunity for us to reflect on the lessons learned and how best to engage communities in the response to a health issue. Just because we translate or provide information in language doesn't guarantee that the information will reach communities or that it's understood or taken up. As we learn to adapt to the complexities of life during the pandemic, as a sector, we need to find new and innovative ways to sustain our work with communities around hepatitis B. In recent years, the Multicultural HIV and Hepatitis Service has worked in close partnership with CALD communities most affected. This year, we'll be working closely with the Vietnamese community and also the Mongolian community. As part of the New South Wales Viral Hepatitis Communication Strategy, we've also launched the Are You Living with Hepatitis B? Find Out, Get Tested campaign. It's a multilingual, multi-channel campaign that promotes hepatitis B testing among 5 priority communities: the Arabic-speaking, Chinese-speaking, Korean, Sub-Saharan African and Vietnamese communities. The campaign messages and resources have been co-designed with and nuanced for each community. Our long-standing partnerships with key stakeholders, especially community and faith leaders, community and sector NGOs, and the ethnic media, are vital to help get the messages out. This World Hepatitis Day, we'd like to remind communities of the importance of looking after their health by asking their doctor for a hepatitis B test. We'd also ask that all involved in the New South Wales response consider the diverse cultural and social context of the communities most affected and place them at the core of our work. Thank you.
My name is Wei, and I have hepatitis B. I knew I had Hep B ever since I was little, and growing up with my family, we were told that we had Hep B, but we were never told exactly what hepatitis B would do to you. As Hep B carrier, as they say, that nothing really dramatic will happen to us if we eat well and not sleep too late. But in fact, if we don't treat or ignore the fact that we do have Hep B, eventually it will attack our liver, and before we know it, it's already too late. There's a lot of stigma that's attached to hepatitis B, and I wouldn't recommend anyone to be prejudiced when they do see or know someone who's got Hep B. Well, I guess the message I want to put across is hepatitis is not the end of the world, so not to be afraid, and do go on the website for hep.org.au, and I'm sure that you'll be able to find most of the information at the web address, and I guess that will definitely lead you to a more healthier life.
We've just heard from Gay Stackpool, the Deputy Manager at the Multicultural HIV and Hepatitis Service. Gay was speaking to us about the various complex issues for migrants arriving here in Australia, resettlement issues, and how people are having to prioritise various issues in their life where housing and employment might take first place over healthcare. This is a challenge for us in our work. working with people who may be affected by Hep B, identifying that 1 out of 3 people in Australia with Hep B don't know that they have Hep B, and then looking to how we can work to innovate, to work with communities. And I particularly liked how Gay identified that COVID-19 is disrupting the way in which our work can be achieved, but it's also creating the need for us to innovate and work alongside communities to identify new ways of reaching people and addressing health needs for those communities. So thanks very much, Gay, for addressing us at the event today. We also heard from Wei. Wei was one of our lived experience speakers talking about Hep B. And again, the lived experience of Hep B is very different from other experiences in the healthcare system. Quite often people are struggling to find out the information they need, and also quite often juggling the needs of their privacy, their family, and their concerns around Hep B in relation to the whole family and others affected by Hep B. Our next speaker today is Tom Wright. Tom is working as the Harm Reduction Project Officer in Justice Health and Forensic Mental Health with corrective services settings in New South Wales. Tom is going to give us some information about the progress that they've made in working with people in custody, addressing treatment for Hep C and Hep B.
Hello everyone, my name's Tom. I'm from Justice Health and the Forensic Mental Health Network, and this morning I'm going to provide an update on the elimination of hepatitis in the New South Wales custodial system. I'm here as a rep for Colette McGrath, the Service Director of Population Health, who sends her apologies but is unable to deliver the presentation. She's currently leading the network's response to COVID-19. So I'd like to start by acknowledging the traditional owners of the land where I am currently, the Gadigal people of the Eora Nation, and pay my respects to all elders past and present. I'd also like to thank Hepatitis New South Wales for the opportunity to provide an update on World Hepatitis Day. So in terms of hepatitis C treatments in the New South Wales custodial system, we've now commenced over 4,500 people on DAA treatments, and I'd just like to acknowledge the hard work of all the public sexual health nurses who work in New South Wales prisons across the state, and their efforts to provide access to these treatments to quite a large number of people, many of whom would find it challenging to access healthcare in the community. Over the last financial year, the 2019-2020 financial year, we did initiate 1,236 people on DAA treatment. So, that's a slight drop from the previous year, and I think that we think moving forward it's going to become increasingly difficult to maintain higher numbers of treatment, despite increasingly large numbers of people we're able to test. But we're hoping this is a good news story, and it just means that the hard work that's occurring in the community and in the prison system is resulting in lower rates of hepatitis C for people coming into and in the prison system. In terms of recent treatment numbers, so during COVID-19, between April and June this year, despite a lot of energy going into COVID-19, we have been able to continue to roll out DAA treatment. So between April and June, 360 people commenced treatment. In terms of what some of the key challenges may be moving forward, I touched on COVID-19. At the moment we've been able to maintain treatment, but that there's definitely a big resource cost to the network's response to COVID-19 and from Corrective Services New South Wales as we try and sort of reorientate our services to deal with that challenge. So that's a space we need to sort of keep an eye on. The setting itself is going to present a challenge. There's up to 400 people entering the New South Wales custodial system in 2019, so pre-COVID-19, and once people are in the system, they often move around between a number of centres, are released back into the community, and then unfortunately people re-enter the system. So that high level of movement just really makes the continuity of care around hepatitis C challenging. And the other point worth making is there's now 3 large privately operated prisons in New South Wales, and healthcare in those settings sit outside the remit of Justice Health, so that's a space we need to keep an eye on also. Touching on retreatment and reinfection as a challenge, so up to a third of all the DAA treatments we provide now are someone's second, third, or even fourth treatment. So we are seeing lots of retreatment occurring, and we know that there's reinfection occurring in the New South Wales custodial system. So the challenges around harm reduction without a needle and syringe program are going to remain challenging, and we need to keep working in that space. We're hoping a peer harm reduction program we're going to launch soon with Newer may be an exciting opportunity in that space. Other opportunities and things we think will help facilitate work towards elimination are dry blood spot testing. We think moving forward this is going to be a key tool in allowing us to get outside the clinics. It allows us to test in the yards. It reduces the resource strain on corrective services having to move people into clinics. It's acceptable to people. We think that's going to be a key tool. During June, we provided 180 DBS tests, and through that we identified 25 people who were hepatitis C positive. Another opportunity for the future is our hepatology nurse practitioners. So we've got 2 full-time nurse practitioners who'll be able to start prescribing DAs soon, and that's going to dramatically increase our prescribing window. So currently we have doctors prescribing roughly about 2 days a week, but having 2 full-time staff will really increase that prescribing time frame. And just to finish, I guess I just wanted to touch on hepatitis B. Though there's a lot of focus for us on hepatitis C elimination, population health is also really aware of the higher prevalence of hepatitis B in the New South Wales custodial system, and we are looking to commence a project around point-of-care testing for hepatitis B soon, and we're hoping that through that project we'll be able to start to improve treatment and management for people with hepatitis B and also increase our vaccination rates. So I might just leave it there for today. Thank you.
Thanks so much. You were just listening to Tom Wright speaking on behalf of the team in Justice Health and Forensic Mental Health in the custodial settings in New South Wales. And the Director, Colette McGrath, of course, would also have loved to have been here today. Thanks so much, Tom. It's really fantastic hearing about that success in terms of the numbers of people being treated in the corrective settings across New South Wales, but also concerning that, of course, you're now facing retreatment where people are coming into and out of the system, moving in and out and moving between facilities and being exposed to Hep C again, mainly because there is no access to high quality evidence-based harm reduction in those settings. It's great news as well that nurse practitioners can now prescribe within the settings, so it will really ramp up the access to treatment in custodial settings. So today we've heard from a really wide range of speakers working in the elimination of Hep C and Hep B across New South Wales. We've had some really key themes come through right from the very beginning, talking about working together, working to address stigma and discrimination, to lose the judgment, as Mary Harrod said. And also, why are we doing all of these things? We're doing this so that people can get the treatment that they deserve. We've been living through another larger threatening epidemic with COVID-19. It's really woken people up to the fact that health inequities are following those kind of fault lines that we have in our social constructs around access to health, experience of stigma and discrimination, experience of racism. And now we're looking at reorientating. How do we provide services? How do we overcome those social determinants of health and the impacts that they've had on people's lives? How do we balance up and get services to people who are disadvantaged and vulnerable? So it's really a great time, I think, for us to reinvigorate our work, to reconsider and innovate around the new technologies, the new mechanisms and the new service settings in which we might find ourselves over the next year, and work with and amongst the communities that we serve. Our partnerships are really strong. As you can see, we had a really wide range of partners speaking today at the event, and I think that demonstrates the strength of this sector here in New South Wales, what we have achieved, what we can achieve, and what we will achieve. Now, before we wrap up for the day, thank you to the 87, 88, 89 people that have joined us here today as guests. And thank you so much to all of our speakers and for their time in preparing and attending to the event today. I'd also like to acknowledge the technical team that sat behind the broadcast today, and particularly thank the staff of ACON who provided advice on working with this platform. That was Liz Duck Chong from ACON, and also our rehearsal actor, Naomi. And last but not least, Grace Crowley, who is behind the scenes working the technology and making this possible. So thanks everyone for all of the work that you've put into your presentations, for guests attending today, and thank you so much to our tech team. Happy World Hepatitis Day, everyone. Thank you.